Morning and welcome to the webinar focusing on long COVID in children. I'm Dr. Susan Coe, a family physician of 33 years in Richmond, BC, and a clinical associate professor with the UBC Faculty of Medicine. I am a member of the Canadian COVID Society, a national nonprofit organization that works to inform the public about the health consequences of COVID infections, to advocate for science-based measures to reduce the transmission of the virus, and to empower and support the people with long COVID. The Canadian COVID Society is organizing events across Canada as a part of the International Long COVID Awareness Month for March 2026, with the last week dedicated to bringing awareness of long COVID in children. As we enter the 7th year of the COVID-19 pandemic, healthcare professionals and the general public still have limited knowledge about long COVID in children. Worse yet, there are some healthcare groups that continue to minimize the effects of COVID in children and have classified the symptoms of long COVID in children under the umbrella of psychiatric somatization disorders. Today, we are honored to have two notable physicians in the field of long COVID in children who will be sharing their expert knowledge to increase awareness on this topic. Dr. Rachel Gross is an associate professor in pediatrics and population health at the New York University Grossman School of Medicine and a multiple principal investigator for the Recover Research in COVID to Enhance Recovery Clinical Science Core. She's one of the lead investigators in the comprehensive study characterizing long COVID in adolescents and children, published in August 2024 in JAMA. Dr. Alexandra Yonts is an attending physician, infectious diseases, Children's National Hospital, assistant professor of pediatrics for George Washington University School of Medicine, and the director of Children's National Post-COVID Program Clinic. Thank you very much, Dr. Gross and Dr. Yonts.
Thank you so much for having us here today to talk with you. So thank you so much for having us here to share with you about pediatric long COVID. Where do we stand? As you mentioned, I serve as a multiple principal investigator for the NIH-funded Recover Clinical Science Core, as well as an invited expert panel member on the CDC-funded expert panel on long COVID education, engagement, and care management that's led by the Council of Medical Specialty Societies in the United States. Dr. Yonts has previously served as site PI for a Pfizer vaccine clinical trial for COVID-19 and Lyme vaccines, and her institution received funds to conduct these trials. So I always like to start with the words of families with children of different ages that are living with long COVID. So one mother of a teenager shared, "My teenage daughter had COVID in December 2022, and months later, she is really struggling. She has been out of school for 6 weeks with debilitating fatigue, pain, and brain fog, none of which show any sign of letting up. All in all, COVID has been a devastatingly difficult journey for my family, and it is not one I wish on anyone." Another mother of a school-age child shared, "For over 3 years, long COVID has derailed my family's life. My 11-year-old with long COVID has missed over a year of school due to long COVID-induced fatigue, brain fog, POTS, and celiac. My own long COVID journey has made caregiving a balancing act. With our lives turned upside down, we wait for a clearer path ahead." And another mother of a young child shared, "When my daughter was 5, I dropped her off at school and didn't even leave the parking lot before they called me back. She had passed out on the carpet and was too weak to sit up. That was 2 years ago. I took her to the doctor that day and learned it was long COVID. Now she is able to go to school most days, but when she catches an infection, it can take her 2 weeks to recover. I wanted to read these quotes to really honor the experience of children of all ages and their families, really highlighting the urgency for research focused on pediatric long COVID. So, what are we going to talk about today? So, this slide summarizes our agenda. First, we're going to discuss what is long COVID. In particular, what are the current definitions, the epidemiology, and the known risk factors for developing long COVID? How does long COVID differ by child age? What are the mechanisms related to the development of pediatric long COVID? How do we care for children with long COVID? And what are the next steps in order to identify specifically the underlying mechanisms that could be used as targets for treatment? So, what is long COVID? We are learning quickly at the beginning of the pandemic from other infection associated conditions that existed prior to COVID and the words of families as they were getting sick over time that long COVID was a heterogeneous condition, meaning that different people were experiencing different symptoms. And this led to challenges in creating a precise definition. In addition, at the beginning of the pandemic, this was complicated by the fact that different groups or countries were using different names for this condition. So, for example, in the United States, the NIH commonly used the term post-acute sequelae of SARS-CoV-2, or PASC. The CDC commonly used the term post-COVID-19 conditions. This is also the term that was commonly used in Canada as well. The World Health Organization often used post-acute COVID-19. And then other studies and communities were starting to use more plain language terms such as long COVID, long hauler, or long-term COVID. And having all of these different names created challenges for conducting research and also created confusion within the community. But over time, a consensus was starting to evolve around what the broad definition looked like. And there were lots of different institutions that broadly were defining long COVID as symptoms, signs, and conditions that develop, persist, or relapse over time after a SARS-CoV-2 infection, and that these symptoms can last months or even years after the acute infection resolves. And they're often associated with debilitating effects that can severely impact one's quality of life. The Canadian guidelines for these post-COVID conditions were building on the WHO definition, defining long COVID within 3 months of a known or suspected infection, lasting at least 2 months with persistent or relapsing remitted symptoms, and having significant impact on daily life. In 2024, in the United States, the National Academies of Sciences, Engineering, and Medicine established a NASEM definition to try to pool together all of the evidence that was existing at that time. And building on this available evidence, they worked to create a very broad, sensitive definition. And this slide really summarizes what that is. So it stated that long COVID is an infection-associated chronic condition that occurs after SARS-CoV-2 infection, is present at least 3 months as a continuous, relapsing and remitting, or progressive disease state that affects one or more organ system. And they really highlighted 5 key areas as part of this definition. They highlighted that while we do want this to be attributed to the SARS-CoV-2 infection, a laboratory confirmation is not required to make this diagnosis. And long COVID can follow any severity of the acute illness, including those that were asymptomatic. They highlighted that these symptoms should be present for at least 3 months. They described there are more than 200 different symptoms or associated conditions that have been described. That both adults and children can be affected by long COVID. This was very important that this was included in this definition, and that there needs to be functional impact, and that this can include profound emotional or physical impact and affect one's ability to work, attend school, interact with their family, and do regular activities. And so we know that millions of children worldwide are experiencing long COVID, yet pediatric research for long COVID has been limited. Most of what we know about long COVID comes from studies of adults. And when it comes to long COVID in children, there are many more questions than answers. These gaps in our knowledge stemmed from several common misperceptions. Specifically, the misperceptions that children do not get long COVID. And if they do, their symptoms must be the same as those of adults. And if they do get long COVID, they must get better quickly. And so we know now that these statements are not true, and they have led to a significant under-recognition of the public health crisis facing our children today. So, what is known about the epidemiology and the risk and protective factors for developing pediatric long COVID? So, we know that long COVID is a significant pediatric public health problem. And while estimates of prevalence have varied widely across studies due to different study designs, it is likely that the prevalence falls between 2 and 10% of children with a history of a COVID infection. And to put this in context, if an estimated 65 million children in the United States were found to be antibody positive, then this would be about 1.3 million to 6.5 million children that could have long COVID. And this is comparable to the 4.6 million children that have asthma, the 500,000 children with epilepsy, the 15,000 children diagnosed with cancer each year, really highlighting how long COVID in children is not a rare condition. Risk factors for developing long COVID have included both infection-related factors as well as host-related factors. With more severe acute infection, a greater number of initial symptoms, those who were affected by earlier variants, as well as those with a history of multiple reinfections, all having an increased risk of developing long COVID. As well, in addition, those that were unvaccinated, children that were older, those with a history of allergic and respiratory disease, a history of obesity or ADHD or hypermobility, as well as certain social determinants of health also increase the risk. But what I wanted to highlight about all of these factors is that while they increase the risk of long COVID, many children without these factors have developed long COVID. And so this is important to remember when you're seeing children for care. Just to provide a little bit more information about some of these risk factors, research has been coming out about how vaccination against COVID-19 can reduce the risk of long COVID. And this has been hypothesized to occur in 3 ways. First, vaccination can prevent some infection from occurring, indirectly preventing long COVID. Second, vaccination can decrease the severity of the infections that occur. And as I mentioned, more severe infections increase the risk of long COVID. And third, vaccination may mitigate the longer-term pathophysiologic response that is occurring after an infection. And so, one of the studies that was recently published in Vaccine demonstrated that in children with a history of a SARS-CoV-2 infection, that vaccination played an important secondary prevention role in limiting the progression to long COVID by 36%, despite having the infection already. I also wanted to highlight a recent study in the United States published in JAMA Pediatrics that explored social determinants of health and found that a family's environment and resources matter, and that food security, financial stability, and social environment are some key social predictors about whether a child will develop long COVID. And this really highlights that addressing adverse social determinants of health may mitigate future disease risk. And I know that social determinants of health in Canada may be different and thus needs to be explored. So, how does long COVID present in children and adolescents? And are these symptoms, how do they compare to those that we see in adults? So I wanted to share, Dr. Yonts had put together a little summary of some real children that she cares for that are living with long COVID. And these are some examples of what you might see. So a 17-year-old girl with fatigue, headaches, daily nausea, and lightheadedness for the past 6 months, which started 3 weeks after the acute infection. She's unable to attend school regularly for 5 days a week and can often manage to go 2 to 3 days per week. Another 11-year-old girl experiences prolonged chest pain, palpitations, and fatigue, which has progressively been worsening since her third COVID infection 12 months ago. She is unable to participate in activities that she was commonly participating in before, such as taekwondo or ballet. And a 10-year-old boy is experiencing recurrent episodes of fatigue, post-exertional malaise, brain fog, and worsening OCD symptoms, starting 3 months after their acute COVID infection, which was 2 years ago, with increased frequency of these episodes over the last 6 months. And he is unable to attend in-person school because of these episodes. So, what are the symptoms that we should be looking for in children? And so, similar to adults, long COVID in children is also a heterogeneous collection of symptoms, with different symptoms presenting in different children. And they can occur in almost every organ system of the body. And this is a figure that highlights all of the different systems involved that was included in a review article published in Pediatrics. We wanted to highlight some of the most common symptoms, and you might hear these in the cases that I described. So data from both research and clinical cohort studies have shown that the most common symptoms in children and adolescents include fatigue, headache, body pain, as well as exercise intolerance. The Recover Pediatric Study, published in JAMA in 2024, a manuscript characterizing long COVID in both school-age children as well as adolescents. And overall, this article found that symptom patterns are similar but distinguishable across age groups. We found that symptom clusters or different types of long COVID differed by age group. And so 2 of these clusters that you see here in the middle are found in both school-age children and adolescents, as well as in many adults. And so one of the clusters includes many different symptoms across multiple organ systems. These are the children with the greatest symptom burden. A second includes children where their symptoms are predominated by pain, fatigue, and low energy. But we found 2 unique clusters in the school-age children. One was characterized predominantly by trouble sleeping and trouble with memory and focusing. And another was characterized predominantly by stomach pain, nausea, and vomiting. And finally, in the adolescent group, we had a unique cluster where the primary symptom was change or loss in smell and taste. Thought, well, what about our youngest children, the children between birth and 5 years old? And so we published a manuscript in JAMA Pediatrics characterizing long COVID symptoms in early childhood. And we found that the most common prolonged symptoms in early childhood were those that are most easily observable by the caregiver. In infants and toddlers, the most common prolonged symptoms included trouble sleeping, fussiness, poor appetite, stuffy nose, and cough. And in preschool age children, the most common prolonged symptoms included dry cough and daytime tiredness, sleepiness, and low energy. In addition to finding symptom clusters in research cohorts like I described, there have also been work to describe symptom clusters in clinical cohorts. And so this is work by Dr. Yonts in her clinical cohort, where they found that many or all of the patients were describing some generalized key symptoms that I mentioned, such as fatigue, decreased exercise intolerance, headache, cognitive dysfunction, and lightheadedness. And then other symptoms which were clustering in different groups. One where they were seeing groups of children that were more likely to have GI, neuro, and musculoskeletal symptoms. Another group where they were seeing more cardiopulmonary symptoms, and another where they were seeing more severe inflammatory related symptoms. And so all of these findings really highlight the different types or phenotypes of long COVID that we need to be looking out for. I also wanted to highlight that in many individuals or patients, the constellation of symptoms triggered by long COVID may also correspond to other predefined post-infectious conditions. And this slide highlights a few that we need to consider. One is dysautonomia or POTS. Dysautonomia is when there is a disruption in the autonomic nervous system, which controls essential functions like heart rate, blood pressure, and digestion. And COVID-19 has the potential to worsen or initiate this condition, leading to symptoms such as lightheadedness, loss of consciousness, or rapid heartbeat. And postural tachycardia syndrome, or POTS, is a disorder that falls in this category that can cause an abnormally fast heartbeat when standing up. Another is ME/CSF, which is a disease characterized by profound fatigue, cognitive dysfunction, sleep abnormalities, and autonomic manifestations, pain, and other symptoms. And the final one I wanted to mention is mast cell activation syndrome. And this can develop as a spectrum of mast cell disorders. Often, when these mast cell mediators are released, it can lead to different symptoms, particularly allergic related symptoms. And so comes from the website of Long COVID Families, and we have the website here if anyone's interested in learning more about these associated conditions. I also wanted to highlight a key symptom that is very important to recognize. And so this is post-exertional symptom exacerbation, or commonly called post-exertional malaise, or PEM. And it's defined as a flare of symptoms or the appearance of new symptoms after exertion, often presenting 24 hours after a triggering event. And this is a hallmark symptom of ME/CFS, but also is seen in many people with long COVID. And so PEM really can be screened using questions that we highlight here, really assessing this push and crash cycle that you might see. And so, an example of a screening question might be after an activity, do you have worsening of your fatigue or other symptoms that is delayed in onset by hours or days, is disproportionate to the activity that you were doing, and has a prolonged recovery? There's some resources here that highlight some screening tools. And I wanted to talk about this because graded exercise therapy or standard physical therapy that may often be prescribed can be harmful for patients that have PEM. And so it's really critical to identify PEM before recommending any rehabilitation or exercise programs. And
All right.
so now I'm going to hand the presentation over to Dr. Yonts.
Thank you, Rachel, for putting all of this in context about what we're seeing and learning about children with long COVID. I'm going to talk a little bit about the mechanisms and proposed pathophysiology that we've seen, with caveats that most of these studies come from adults, although there has been some pediatric data collected. And then we'll also be touching on evaluation and management of these patients before I hand it back to Rachel to wrap up our talk about future directions in this space. So long COVID, as Dr. Gross previously mentioned, is considered an infection-associated chronic condition. And I would say if there's one good thing about the COVID-19 pandemic and the appearance of long COVID, is that it has really brought into, highlight this idea that infections do in fact have lingering consequences in many individuals. This is something that has been known, I would say, by small groups of individuals and communities, those struggling with ME/CFS and post-Lyme, which have both been around for decades. But we are now starting to pay more attention and look at more mechanisms of all of these conditions. And there is very likely a degree of overlap in terms of what's going on in the body in all of these types of syndromes. So there is evidence across different spaces in all of these infection-triggered conditions that there's some genetic component, that there's some evidence of ongoing autoimmunity or chronic immune activation, and that there may be roles of endotheliitis and, dysautonomia with all of these. So I think it's definitely a paradigm shift for most of us as practicing physicians. Usually we think you got a virus, it's gone, and you have no problems from that, or an infection is treated with bacteria. But really, we are learning more that it is not that straightforward, and a lot of people are going on to suffer, and we should be figuring out how to adjust that or fix that. Getting into long COVID specific research. Oh, next slide, Rachel. There has been, again, a wealth of information in the adult space looking at the different processes happening in patients that continue to have symptoms after COVID. Whether these mechanisms differ for children remains unclear, again, because we don't have the specific bulk of data, although we are gathering specimens in biorepositories, so hopefully we'll get more information on that in the coming years. But in the adult space, we have sort of talked about the risk factors, but there is evidence in patients that continue to have symptoms and don't fully recover, those with long COVID, of potential viral antigen persistence. And I'll talk about most of these mechanisms in additional detail in the coming slides. There's also evidence that there is ongoing inflammation, sometimes in certain tissues. The degree and extent of that may be variable by individual, but inflammation is a key finding in these patients. Going along with that, things like dysbiosis, so disruption to the microbiome, largely in the gut is what we've studied, but very possibly in other parts of the body, which also impacts sort of latent viruses that we know are activated in any pro-inflammatory state. And sort of more novelly, this concept of endovascular dysfunction or inflammation in the blood vessels leading to microemboli. So all of these have been demonstrated in patients with long COVID, mostly in comparison to those that either fully recovered from their symptoms after infection or compared to those pre-pandemic controls or individuals that somehow escaped COVID infection in the early years. Next slide. So, I will talk about the first sort of buckets of this as what are thought to be maybe the main drivers of disease in long COVID patients as sort of the upfront or initial phases of pathophysiology. And then subsequent sort of buckets, may be downstream effects of that pathology. So, for example, ongoing inflammation can lead to damage in the blood vessels that can lead to microemboli. So the kind of first, and I would say maybe area that has the most interest in therapeutics at this point is the immune and inflammatory dysregulation that is seen in this population. So numerous adult studies have looked at presence of various antibody markers, immune cell distributions, lots of flow cytometry to tell about different T cell, B cell subsets. And it really is emerging that there's in most individuals with long COVID, or many of them, there's a miscoordination or discoordination of the humoral response and the cellular response. So some studies have shown that patients, as an example of this, with very low or absent SARS-CoV-2 antibodies prior to infection end up having a really robust and prolonged SARS-CoV-2 specific T cell response, essentially T cells making up for what the B cells have not been able to accomplish for this infection. As a result of that, or related to that, there are also higher levels of IL-4 in long COVID populations, which affects T helper cells, T2 helper cells. And, as a consequence potentially of this, there are higher markers of what's called exhaustion in CD8 positive memory T cells that are specific for long COVID, sort of suggesting again that patients are having this T cell response that's trying to make up for other parts of the immune system that aren't acting appropriately. Similarly, elevated levels of monocytes and plasmacytoid dendritic cells and elevated levels of complement, which can be an inflammatory marker, but also could be a part of this hyperactivity in the immune response, are all very notable. So one thing to point out on the graph on the right is some violin plots showing healthy controls in the orange bars, recovered long COVID or recovered COVID patients in the yellow bars, and then long COVID patients in the purple sort of plots. And just showing that, again, those levels of monocytes, of a lot of the immune cells, as well as anti-spike antibodies, sort of as their symptoms have progressed, are much higher in the purple section than they are in the other, both recovered and healthy controls. The bottom graph is demonstrating a cohort of patients where they compared the receptor binding domain spike antibody sort of count to the specific sort of T cell recount. And it just demonstrated in those red dots, which are long COVID patients, that several of these individuals that had the lowest antibody did have the highest sort of T cell response. So definitely, an immune component. We still don't know why certain people's immune systems aren't reacting the way that we would expect and why others do, but it's a huge clue to lines of inquiry that need to be performed. Next slide. Maybe related to this, although there's some, sort of ongoing questions, is the concept of viral antigen persistence. So, we typically think about COVID or SARS-CoV-2 as being this respiratory illness, but there is actually, several studies, both from autopsies from patients that passed away from COVID, and in individuals with long COVID, that there is persistence of parts of the viral antigen. So either specific spike, nucleocapsid proteins, or even RNA in various tissues across the body that have persisted for up to 900 days and possibly even longer. And these have ranged anywhere from the brain to the gut to the liver to the skin. So really, suggesting that this, virus can get into the tissues. And in fact, that might be where we get some of this prolonged inflammatory response. This is important to note because a lot of studies have been solely focused on looking for viral antigen in the blood. And that has not necessarily been something that we've easily seen long term. So tissues are harder to sample, harder to test, but it's likely where the money is in terms of looking for viral antigens. And one, additional component that supports this is the evidence of this prolonged antibody response, as well as that prolonged T cell response, as I mentioned in the previous slide, in patients that have long COVID symptoms. So a great study showed that particularly in the early post-COVID phase, 4 to 8 months after the initial infection, that long COVID patients had sustained production of antiviral cytokines. They had higher levels of anti-spike protein and antibodies, and that typically actually did resolve by 24 months post-infection. But as having that increased setting in the early post-infectious phase may set the pathway for other pathologies down the road, causing some damage that is maybe harder to reverse, even if the virus itself is ultimately cleared or parts of the virus are cleared. Next slide. So long COVID patients have been demonstrated to have autoimmunity, sort of, related to immune dysregulation, but it's a little challenging of whether this is truly a result of long COVID or could be a cause. So we do know that there is a risk factor of having sort of autoimmune diseases, allergic diseases, putting individuals at higher risk for development of long COVID. And some of the individuals that, get long COVID have sort of elevated autoantibodies prior to infection. But we have certainly seen an emergence of many autoantibodies produced in long COVID patients compared to controls over the course of their ongoing illness. So a non-specific elevated ANA is very common across a lot of patients, including children, as I can speak from clinical experience. Similarly, anti-thyroid antibodies, so anti-TPO and anti-thyroglobulin are often very elevated, with no evidence of direct thyroid disease at the time, but it serves as a marker that there is something going on with the immune system that is continuing. Related to this, there is an increased incidence of new autoimmune disorders that's really been demonstrated in the adult population, but anything from Sjogren's down to inflammatory bowel disease. And one kind of interesting, cool, basic science sort of concept of this is that they took immunoglobulins, so just a random swath of IgG from long COVID patients in their blood, and gave it to mice. And it actually caused some hypersensitivity in terms of sort of sensory input as well as neurologic symptoms. So that bar graph on the bottom right demonstrates in the blue sort of normal responses or control responses in mice who didn't receive IgG from long COVID patients. And then in the purple, it shows markers of kind of these chronic pain concerns, so this sensory hypersensitivity and neurologic symptoms. So that suggests that there actually may be something to the specific immune response that's created in long COVID patients that induces these this damage in individuals. So, again, a very important line of inquiry for looking at long-term management and treatment of these individuals. Immunomodulatory treatments are something that are actively being explored and considered, but certainly something that is a process that we've seen in these individuals. Next slide, please. Which takes me to getting into the more of what I conceptualize anyway as sort of the downstream results of some of these ongoing inflammatory and immune responses. So there have been multiple studies across different parts of the vascular system that have shown that there is a relationship between SARS-CoV-2 infection and development of clotting disorders or clot breakdown disorders. So one really great study that was published in Nature in 2024 showed very nicely that fibrin, an increased fibrin, which for those of you that remember is one of our basic sort of clot proteins, is really driving a lot of the ongoing inflammation and, is associated with sort of the neuropathology and symptoms that we see of brain fog and things like that in acute COVID-19. And that sort of tags along with studies that show that there are disruption to the endovascular tissue, that there's production of various enzymes that related to that damage impair breakdown of fibrin clots, that in combination can then form microclots with other inflammatory proteins in the body. So a lot of this is still being worked out and replicated. There's sort of one main group that has done a lot of the studies on these microclots, looking at their structure and their number, and additional sort of studies need to be done to look into this and see if it's a more generalized phenomenon. But I can say there's lots of studies showing that there is something going on in the endothelial cells, that there is some impaired fibrinolysis. Which makes sense because we know in acute COVID, strokes and other embolic phenomenon are a very clear pathology. And so this is happening on a smaller, more chronic level in individuals, and very likely contributing to symptoms. Next slide. So I just as a reminder, this is the coagulation cascade, and what we're talking about is production of these markers of fibrinolysis. So things like tissue plasminogen activator in particular, that normally would get plasminogen going, which creates plasmin, which is what breaks down fibrin clots. But in the case of many of these long COVID patients, that is actually elevated. So you are an inhibitor of that is elevated. So you're not getting the activation of that conversion to plasmin. So you're not getting the breakdown of fibrin clots, which is like the fibrin monomer is what it's referred to, or getting that conversion to sort of breakdown products. So I think that there's more work to be done on sort of the timeline of these markers and the impact of treatment. There have been early studies looking, kind of at combination anticoagulation therapy, but again, need to be done in a broader controlled fashion, and in multiple populations. Next slide, please. So as I was mentioning, that is the biggest study done by this the group in South Africa that have, shown these microclots in the microscopy in individuals with long COVID that are not present in those either recovered or with, without COVID infection, but has just been limited to that research setting and needs to be sort of evaluated more broadly. But one sort of, I'd say cross-disciplinary study that I think is really interesting is there was a study of 54 adolescents, so an actual pediatric study using a sort of post-resolution, a type of specialized contrast MRI, comparing lung imaging, so specifically lung perfusion and ventilation in 27 teens with long COVID compared to 27 controls. And in that study, they showed that there were an increased number of these very small sort of subsegmental perfusion defects in long COVID patients, and that those were associated with a higher incidence of cardiopulmonary symptoms, tachycardia, chest pain. So that this may kind of bridge the gap, showing evidence that there is some sort of disruption or inflammation in the microvasculature in the lungs. So, working to connect these two things, I think, is a good next step. But just emphasizing that there is a huge vascular component to long COVID that we should all be aware of. Next slide. And then again, as Dr. Gross mentioned, dysautonomia is something that we see in a fair number of our long COVID patients. So to put it in perspective, I think POTS, postural orthostatic tachycardia syndrome, is maybe the dysautonomic syndrome that we are all most familiar with as pediatricians, and that affects approximately 1% of the general population. But in contrast, one study has shown that it's affect at least 13.8% and maybe even higher if using less strict definition of POTS, so of having other forms of dysautonomia or those having a negative tilt table test but meeting criteria with other types of dysautonomic testing. One study kind of early on has demonstrated that there is a relationship to POTS and dysautonomia with small fiber neuropathy, which makes sense. Autonomic nerve fibers are small fibers, and so if you find that there is disruption, damage to that on a sort of peripheral skin biopsy, there is some more hard evidence that there is a process that is creating this rather than just being something that these patients have had their entire life. Next slide. So in summary, I think just trying to drive home the fact that this is a biological process. Long COVID, just like many of these other infection-associated chronic conditions, have ongoing pathophysiology that has been studied in a controlled research space. We're still piecing together the exact relationship of all of these findings in terms of which patients have these, what's the sort of progression, the time frame of development of these different processes, but they are there. This is a biologic process, and the good thing is these mechanisms ultimately will, be something we can look at for possible treatment of not just symptomatic management, but also maybe the ongoing process that's driving the disease. So moving on to a more clinical aspect, the evaluation and management of patients with long COVID in the pediatric space. So, I like to start this section with what can a primary care physician do? What can I, as not me, but you, as a pediatrician out in the community, even a pediatric subspecialist out in the community, to evaluate and help identify patients with long COVID? I think I say easy, although I, respect that all of us, and especially primary care physicians, are overburdened with the amount of tasks that are asked to be completed in a single visit and in a single day. But I think a step that can potentially be implemented in your practice is doing some degree of evaluation after patients that have had a COVID infection. This could also extend to anyone that that's had a viral infection, and having some kind of screening or check-in, could be a portal message, a nurse call, in that 4 to 12 weeks after that acute infection. And just say, hey, have you recovered? Are you having any ongoing symptoms? And if the answer is yes, that they are having ongoing symptoms, bringing them in to do some screening and initial blood work for potential causes of those symptoms and potential factors that may delay their recovery further and may require a different lens. So I, propose that there are two things that every pediatrician can do in their office with the tools that they have at their disposal. One of those things is screening for post-exertional symptom exacerbation or post-exertional malaise, with those questions that Dr. Gross highlighted earlier, or the formalized questionnaires, which exist but are very lengthy and maybe less practicable for using in a real-time clinic visit. So starting with kind of those 3 question screeners is a good idea. And then screening for orthostatic intolerance. So any patient with ongoing fatigue or dizziness, lightheadedness, very easy to get orthostatic vitals, something that your MAs can do before you even see the patient. And then something you can perform in clinic is called the NASA 10-minute lean test, which I'll discuss on, I think, the next slide. Other things, if really, again, fatigue is a very common thing, there's basic blood work that can be done to rule out other causes that are unrelated to this, or at least other treatable factors, even if they are COVID related, which include thyroid studies, an iron panel, and a ferritin. I will say that we have a huge number of patients in our population that have very low ferritins, that are not anemic, but there's been a good amount of literature emerging over the last decade that low iron and ferritin in and of itself can produce fatigue. So something that can easily be intervened with iron supplementation in the outpatient setting, as well as screening for other findings. A lot of these labs will likely be normal, but this is just a low-hanging fruit of things that you can do to treat. as well as doing standardized scales to kind of measure progress in an objective way. So there are sort of sleepiness scales, fatigue scales, promise modules, things like that that you can try to implement in a real way, and using, things like REDCap can just send to patients before their visit to monitor their progress. I think where most people end up is, if these symptoms persist greater than 12 weeks and are now hitting that sort of long COVID definition mark, you might need additional help. So, getting engaged with your subspecialists in the area, or, in a perfect world, getting plugged in with an interdisciplinary long COVID program. Admittedly, I know that there really aren't any of those in Canada, and frankly, there are only like 4 in the United States working with kids. But this is something that I think, ideally will change in the future, or at least be able to establish consortiums or sort of group shared protocols across disciplines to help manage these patients in a more coordinated manner. Next slide. So as I mentioned, the NASA 10-minute lean test is something that, I have started doing with my patients in clinic. It's a bedside version of a tilt table test, and it's, I would say, less cruel and much less expensive than doing a formalized tilt, and has pretty good sensitivity, although needs broader study like everything we've discussed in today's talk. So kind of basics of this test are, if a patient has already been sort of under concern or treatment for a dysautonomia syndrome with POTS, meaning they're already doing increased electrolytes or fluids, that ideally they would sort of hold off on that for 48 hours. You want them at sort of their baseline status. And what you do is you have them lay down for 5 to 10 minutes. So you could have the nurse get them that way when you first, get them roomed. And then you will take blood pressure and pulse, just with a basic pulse oximeter and blood pressure cuff for minutes 1 and 2 while they're laying down. And then you'll have them stand up very carefully in case they are somebody that has dizzy, and then stand with their feet 6 inches from the wall, and then otherwise leaning against the wall, as is the picture on the left on this slide. And then you will just take blood pressure and heart rate every minute for 10 minutes while they stand there, as well as record and ask the patient to tell you any symptoms they might be experiencing during that time. If they're getting dizzy, if they're starting to have heaviness or pain in their extremities. A lot of these individuals experience sort of color change, redness, purple, discoloration to their hands or feet, or palpitations. If they start having any of those symptoms or meet criteria for positive results, which are shown in the blue box below, you can kind of stop the test early. But it, again, something that can be done. You can have a parent help time with their phone, or even the patient time with their phone at these minute intervals. And you can continue to ask your questions during this test that you would do otherwise in clinic. So positive results. So orthostatic intolerance is a term that we throw around a lot, which really just means that they get symptoms with transitions. And that in and of itself is something that can be measured conservatively with fluids and electrolytes and those things without having a formal POTS diagnosis. But to meet a diagnosis of POTS, you would see an increase in the heart rate by 40 beats per minute, or 30 if the patient is over 18, because we like to draw arbitrary lines, or they develop a heart rate of greater than 120 beats per minute within kind of the first anytime during that 10-minute time frame. And sometimes it takes a few minutes. Many of these patients have an intact immediate compensatory sort of measure, but it wears off after a few minutes. And all of that is done in the context of not having orthostatic hypotension, so having a blood pressure that drops too severely early in the test. So again, these are available online. You can Google NASA 10-minute lean, and something you can easily grab and put into your practice. Next slide. So kind of beyond what you can do in clinic, these are kind of things that we do when we've really established that long COVID definition in our children. So one of the biggest themes, and one of the, again, easy thing that can be done is validation. I cannot tell you how many patients, and granted, we're all learning and have been over the past 6 years, but how many patients come to me saying that everyone tells me there's nothing wrong with my child. The lab tests are normal. they're just depressed, they're just, whatever, anxious, and ignoring all of these other symptoms that these kids are having. So acknowledging that long COVID is a disease, that it's a biological process, and that yes, your child has this and is experiencing this, goes a long way. Even if you follow it up with, but I don't know what to do about it yet, but I will help you look and figure it out. I mean, that is a huge thing for these families and really helps us all in the medical profession with our sort of trust issues that have been emerging since the pandemic. Similarly, also providing support. So many of these kids have been super high functioning, potential Division I athletes who are now suddenly bedridden. So there's a lot of coping that is needed and helping them adjust to this new chronic disabling condition. So providing support for mental health resources, not for treatment, but for support. One, tenet, especially of those that have post-exertional malaise, are what we call the 4Ps. And I'll talk about this on the next slide, but these are really measures to avoid crashes and to help patients conserve energy so that they are able to function on a daily basis. Sometimes, especially if those patients have POTS, that gradual goal-directed sort of increases in physical activity can be helpful, but you want to make sure there's no red flags. So no red flag symptoms for cardiology, if they have chest pain with activity or things like that, you would want to get them screened with an EKG and echo first, but that's not a universality. So really looking for those red flag symptoms. If they have positive on that post-exertional malaise screener, you don't want to throw them into this category, or if they have really severe dysautonomia. So some people are triggered even by just sitting up. Those would be people that would not be good candidates for like physical therapy and may need some advanced sort of autonomic types of therapies. Similar to the physical sort of return to functioning, having a gradual goal-directed increase to mental activity, similar to what we had done in a concussion protocol. And that can often be working with the school to develop accommodations as these kids are getting back into that space. We mentioned exertion as a trigger of post-exertional malaise, but that could be cognitive exertion. So many kids just going to school, or the noise and the din that's around them at school can be a trigger that saps their energy. And so figuring out ways to support them as they continue this recovering process academically is important. And then some kind of easy, again, first line things. If there's any signs of orthostatic intolerance or dysautonomia, you can increase fluids and electrolytes. It's really not going to hurt anybody to do that. And one formula that's easily used is 8 times the age in years, number of ounces of water per day. And that's a good sort of early sort of goal for anyone that is having those dizziness symptoms. Adding electrolytes, compression stockings can also be helpful. And then if you have that cohort, like Dr. Gross mentioned, of loss of taste or smell, there is olfactory training regimens out there available on the internet, and you can even buy kits for it that can be helpful in restoring and retraining that. So as I mentioned, the 4Ps for sort of energy conservation and management of crashing or crash avoidance are pacing, prioritizing, positioning, and planning. See, these are all things that we want kids and families to sort of frame as ways to go about their day without crashing. And a lot of these are maybe concepts that are foreign. Kids are used to going, 100% everything all day and then going to sleep and calling it a day. So the idea of pacing and saying, okay, you have a math test today, so maybe you need to not walk the dog. Or maybe you need to not read this other book or play this video game, but you can do it tomorrow when you don't have that test. Thinking those things out, and again, family is a huge help with this. And that kind of goes hand in hand with prioritizing. So, knowing what you have to do today, and working around your other things, but hopefully arranging in a way that you can still do all of these things. Making life easier, positioning. So if you don't have to stand, you can sit. If you don't have to walk, you could sit. Those sorts of ideas to energy conserve, again, and especially in important scenarios. And all of that, comes down to planning. On the right are just some visuals, and I'll say there's a lot more on the Long COVID Kids and Long COVID Physio websites to kind of get a visual representation of what the four P's and these represent. So the kind of bucket and energy expenditure model is a good one. The spoon theory is another one. But I really like there's a handout Pacing Penguins that is really great on their website. So there's lots of tools out there, for more visual learners to kind of understand this concept. So as I kind of alluded to, there's no sort of one cure for long COVID at this point. Really, most treatment or management is focused on symptom-based and system-based kind of existing management as well as rehabilitation strategies. That being said, many of us in the clinical space have started to extrapolate from other sort of post-infectious syndromes or dysautonomia syndromes. So using things that have been tried in like post ME/CFS, things like coenzyme Q10, low-dose naltrexone, and many of those other sort of repurposed drugs. There are numerous clinical trials in planning or recruitment, largely in the adult population, although there has been really one in the United States using a medication called lorazepam in clinical trial for pediatric long COVID. And there are about to be some additional studies, hopefully by the end of this year, enrolling children looking at the use of low-dose naltrexone and possibly other interventions in a formalized and controlled manner. There's also ongoing studies looking at sort of the diagnostic aspect, so biomarker development, microclot assessment, and even the effect of rehabilitative strategies. This is just an example. I'm not going to go through all of this, but at Children's National, our post-COVID program is an interdisciplinary clinic. So we have an embedded clinic once a week that includes infectious diseases, psychology, PM&R, and our dysautonomy specialist, who's a cardiology NP, and do some testing from hematology. And we all have our different roles and targets, but talk to each other and have learned and developed all of this knowledge and experience together. And then also have partnerships with neurology and gastroenterology for sort of more symptom specific based issues. I just highlighted that cardiology and neurology, if you're looking for someone for more advanced assistance managing dysautonomia, that those are the two specialties that typically will jump into that, although really, because it spans the entire body system, it is kind of a primary care thing. But at least, establishing knowledge and protocols and learning, those are the two kind of places that you can go. Okay, next slide. And I think we're running a bit late because I love to talk, but there's just some examples of what more specifically can be done or is being tried for addressing neurologic symptoms. So particularly this brain fog issue, which is a non-specific term in of itself, but often describes more specifically memory impairment, issues with focusing, concentration, even spanning to things like derealization or depersonalization. So all of these, can be disruptive, particularly to school activities. And so things, at a baseline, you want to maximize sort of lifestyle interventions, getting good sleep, having a good schedule, addressing stressors. But then if there is continued impairment, neuropsych, if you can get into them, can be a great evaluation for, looking for specific areas that they're struggling with, getting school accommodations to help with these struggles. And then in many cases, trials of stimulants like ADHD agents, and some other wakefulness agents if like falling asleep at school is an issue. So there are some pharmacological interventions that you can try. I won't say that there's perfect results with any, but many kids have really been helped by some of the sort of ADHD meds, even without a diagnosis of ADHD. And then headaches are another particular issue that you can try and address lifestyle factors, which, is frequently a problem for many of these kids, but often referral to neurology, especially many of these kids develop migraines that are seemingly very refractive and need to be managed very highly specialized. But ruling out red flags is kind of a good first step to make sure there's not anything else that requires imaging or more immediate evaluation. Um, Gastrointestinal symptoms, again, is very common and related to dysautonomia. And so there are some basic interventions, optimizing diet, we know fiber, hydration. It's amazing how many kids don't drink enough water, and how it impacts them. There's, emerging suggestions that like pre, pro, and symbiotics may be helpful. And then, GI referral when you're getting into more sort of advanced issues like potential of neuromodulators for disorders of the gut-brain axis that maybe contribute to motility. And then school accommodations, there's a whole host of them. And I think Long COVID Kids actually has some examples of language that might be helpful when discussing with the school, but frequently these kids need, sort of increased rest time, increased time on assignments. They might need adjusted school days. They might need even a period of home and hospital or medical leave, depending on how severe things are. But working with the family and the school to try and optimize any kind of education, even if it is not, the ideal full-time 100% in-person school. And then this is just an example of how I personally manage children with long COVID. So, we see them in our interdisciplinary, multidisciplinary team. We have different types of symptomatic versus lab-based management based on what we find. And that can include a whole host of different medications. Pacing, of course, is a huge thing that we emphasize. And then in those that are sort of most affected that, don't necessarily respond well to that sort of first line or that fourth bar in that graph, progressing to things like low-dose naltrexone or even IVIG in some cases, as things that we've tried in a handful of our patients. Because, as Dr. Gross said, 5-6 years on, there are some patients that were infected in 2020 that are still symptomatic and not improved. So they are, of course, looking for anything that we can do to help get them closer to functional. So we are increasingly doing some experimental medicine in that space. But for other kind of ideas, as the literature evolves, there are guidelines out there, usually more targeted at the broader infection-associated chronic conditions, but including long COVID. The American Academy of Physical Medicine and Rehabilitation has a good set of guidelines. Well, I think they're due for an update. The Bateman Horn Center is a private clinic out of Utah that has a great clinician guidebook on ways to help these families. And then Mount Sinai and their sort of emerging core, so chronic sort of post-infectious condition clinic has a guideline that actually I saw as being adopted by the federal government and sort of turned into a living guideline with the use of AI. So that'll be really interesting to see how that shakes out. But there are these resources out there that can give you some ideas for when you get to a certain point or a certain symptom that you're looking to manage more robustly. And not going to go over this slide, but this is a table from a review article that was in Nature a year or two ago that just shows all the different types of interventions that are being tried for different specific symptoms or disease processes, and some of the sort of data or clinical information behind those. And the yellow boxes that popped up just represent things that we've been trying in our clinic. Although I think those got shifted. So my bad on that. But just pointing out again that there are numerous different interventions out there that can be tried and are being tried in these patients. All right, now I'll turn it back to Rachel to bring us home.
Great. Thank you so much. And so we wanted to end today by talking about what are the next steps in order to identify the underlying mechanisms that could be targets for treatment, because this is the biggest need for the community is moving closer to having effective treatments. And so in the United States, the Recover Initiative was developed in order to be able to lay the foundation for filling the research gaps that exist. And so what is Recover? Recover stands for Researching COVID to Enhance Recovery, and it is a large NIH-funded research project aiming to learn about the long-term health effects of COVID with the goal of being able to better prevent and treat long COVID in the future. And it really is targeted to characterize and understand long COVID across the entire lifespan, including all of pediatrics. And so this is a project that occurs throughout the United States and has enrolled up to 40,000 people of all ages, races, and ethnicities in almost every state. And it was designed to answer key pediatric questions, such as how many children are getting long COVID, why do some children get long COVID and others do not, what symptoms do children feel, how long do they feel sick, what's causing it to happen, and how does long COVID affect later physical health, mental health, and development as children grow over time. And to date, we have over 22,000 participants contributing data to our pediatric study in over 100 sites around the country. And we have a diverse cohort with 8% identifying as Asian, 14% identifying as Black, and 28% identifying as Hispanic. And currently, our pediatric study is following children for up to 4 years, where our initial part of the study conducts baseline assessments in up to 15,000 participants. And a subset of them, about 3,000, are being followed longitudinally over time, coming in for in-person visits at 6, 12, 24, 36, and 48 months after enrollment, with a more intensive piece for about 600 that are most severely affected. And this study has generated a tremendous amount of data on children of all ages, from birth all the way through young adulthood at 25 years old. And so we have over 20,000 symptom surveys, over 5,000 office clinical visits where we're doing flexibility tests, different neurocognitive or thinking tests. We have a tremendous amount of laboratory results, as well as over 20,000 biospecimens that are stored for future mechanistic research. And I wanted to highlight that a special project that is part of the Recover is called the Systems Biology Award, where across all of the age spectrum, including 3,000 children, we are collecting data on dense molecular omic complex data, where we will be creating a repository of data that has the entire genome, transcriptome, epigenome, proteomics, and metabolomic data. And so this will be over 3 billion omic measures that will be publicly available and will lay the foundation for identifying biomarkers as well as therapeutics. And so the goal of this is to be able to characterize the pathobiology extensively, further characterize the subtypes that we see of long COVID from a biologic standpoint, create predictive, prognostic, and diagnostic algorithms, as well as identify specific biologic targets for treatment. And so all of this is the foundation for future clinical trials. And so currently, as Dr. Yonts mentioned, there are almost no clinical trials in children. There's been, less than a handful. And so the NIH has been doing an extensive process to identify what the next trials in both children and adults should be. And it's so key that children will be included in this next round. There was a portal which was open for patients and communities as well as healthcare providers to put in their suggestions for medications that could be considered. Multiple groups reviewed all of these, and these are the 4 interventions that are going to be rolling out in trials in the next year. I want to highlight the first one is going to be a large pediatric trial focused on low-dose naltrexone, as well as the second one listed here for GLP-1 receptor agonists will be a trial that will include children 12 years old and older. Subsequent to are focused on adults. And then this process is remaining open to continue to select trials that will happen after these 4. So I wanted to end with a summary of some of the resources that are out there for your availability, because one of the greatest challenges for families in particular is the lack of awareness for the community of what research is happening. And the community is really working hard to bring these resources to the community as quickly as possible. And so one example that we have been partnering with Recover with an organization called Long COVID Families, which is the largest advocacy organization in the United States focused on children with long COVID. And they really work to bring research studies as quickly as possible. And so this is an example on their website from the studies that we've mentioned. We develop infographics and they're up on their website within a matter of days after publication. And these types of websites are huge resources for everyone caring for children with long COVID. And they've also asked children to share artwork with them about their experience living with long COVID. And I highlighted a few here from a couple of teenagers where you can really see that one teenager is feeling like she's always living underwater. And another one is angry because people are always telling her, you don't look disabled, and not really seeing what she's really experiencing. I wanted to highlight we wrote a JAMA pediatric patient page, which is a free publication from JAMA Pediatrics that really summarizes the variety of different symptoms commonly seen in children of all ages. And we hear from families that they're printing this out, they're bringing it with them to the doctor to provide support for these conversations. I also wanted to mention some of the work we're doing outside of Recover, where the CDC and the Council of Medical Specialty Societies have been working to disseminate research to healthcare clinicians across the United States. And this is really through an initiative called the Long COVID Education, Engagement, and Care Management Project, which is a federally funded project that seeks to provide disciplinary coordination and collaboration across multiple medical societies to improve provider education and engagement in the care of patients with long COVID. And this panel came together. I'm a member of this panel and really worked with different organizations to pool resources together. And these are just some of the highlighted organizations that are part of this. For pediatrics, I'm proud to say that the American Academy of Pediatrics is part of this initiative. And all of these different organizations are putting information about long COVID on their websites. They're creating YouTube videos, blogs, newsletters, social media posts, and doing various presentations to try to disseminate the information as quickly as possible. And these are some QR codes that really link to the living resources that they're going to be continuously updating about the available resources that exist today. I also wanted to highlight the guidelines that Dr. Yonts mentioned from the American Academy of Physical Medicine and Rehabilitation, as well as the Canadian guidelines and the website for this work. And I'll just end finally with, when we mentioned in the beginning the misperception that all children with long COVID get better quickly, there is data really showing that that is not true for many. And so the research on the clinical course of long COVID really demonstrates that there are children with persistent symptoms for years. And this is a study out of Italy where 1,200 patients with a history of SARS-CoV-2 infection, 23% of them had prolonged symptoms at 3 months after their infection. So this is meeting the definition for long COVID. 13% of them had symptoms at 6 months, 8% at 12 months, 6% at 18 months, and then it relatively plateaus. And this is a similar pattern that we see with adults. And so this highlights that children have a significant burden of long-lasting persistent symptoms. And some of these children are symptomatic 6 years now after their infection. And so this is important because there are significant impacts. There are educational costs, healthcare costs, social costs, as well as economic costs. And we must invest in these children to help make them better. And so in summary, our next steps are really to know that pediatric long COVID exists. It can look different than it looks like in adults, that we need to understand the clinical course over time and how the symptoms are changing as children grow, that we have identified risk factors for developing long COVID. More work is needed for understanding why some children have persistent symptoms and why others are improving. And this can really help with the foundation for understanding the pathophysiology, identifying underlying mechanisms, identifying biomarkers, both to help with diagnosis as well as endpoints for clinical trials. And we need clinical trials in children. And we need to develop therapeutics both to address their symptoms as well as to prevent and target the underlying causes. Because we know that pediatric long COVID will impact our population for decades to come. So thank you so much. I wanted to highlight all of everyone involved in the Recover study. It is a huge consortium. We have patients and families, the study sites, all of the representatives, as well as our funding from the NIH. And I'll let Dr. Yonts acknowledge all of our collaborators.
Yeah, and I wanted to thank, largely our multidisciplinary clinic staff at the post-COVID clinic at Children's National, as well as our amazing clinical program coordinator, Allison Lenoki, my boss and mentor, Roberta DiBiase, who's done increasing work in the post-infectious sort of space. And then, of course, all the patients and their families and everyone doing work or even taking interest in this field. It's going to take all of us together to really make a difference. So thank you for your attention today and inviting us to come speak with you.
Thank you so much, Dr. Gross and Dr. Yonts, for such a wonderful, comprehensive webinar on long COVID in children. You've given us so many important insights, so invaluable. So thank you so much to both of you. Unfortunately, in Canada, currently, we have no national provincial programs focusing on long COVID in children, and there has been little effort to track how many children are affected. In the United States, estimates suggest, as you've said, nearly 6 million children may be living with long COVID. This is one of the reasons the Children's Long COVID Network was created, to connect families, clinicians, researchers working to ensure children living with long COVID are better recognized and safely supported. I would like to now introduce Nandini, a parent of a teen who's been living with long COVID for the past 5 years, as well as a healthcare professional and the founder of the Children's Long COVID Network in Canada.
Thank you, Susan, and thank you to Dr. Gross and Dr. Yonts for giving such an important message and presentation for long COVID in children. So I would like to start by sharing, as Dr. Kuhl has just said, that I'm a mother of a teenage daughter who's been living with long COVID for 5 years. She is now 15, and she first caught the COVID infection, the Delta variant, back in when she was about 10 years old. So like many families in Canada, I found it incredibly difficult to navigate her care in Canada with the ease and continuity and trust that you would expect for a child with a serious ongoing illness. Too often, families are left coordinating across gaps, repeating the same story and fighting to be taken seriously. Over the course of the 5 years, we had to seek care outside of Canada. That included Germany, Italy, and United States, simply to find options that might improve her quality of life. And so while there are clinicians in Canada, like Dr. Kuhl, who care deeply, there's far too few that feel able to speak publicly and consistently for our children living with long COVID in Canada. So this continuous experience that we went through as a family is why I created the network, the Children's Long COVID Network, or CLCN. It's to connect families, clinicians, and researchers, and to push the recognition, proper documentation, and biomedical research that leads to real care pathways for kids. We're not alone in this. We had a CLC petition that we had launched last fall that has now reached over 1,300 signatures, supporting our call to the federal government to set up a national strategy for pediatric long COVID to keep our Canadian children visible and to act on it. So our goal is simple. We want to make sure that the children and youth living with long COVID are seen, documented, and supported. A lot of our health system in Canada is built for clear, acute problems. Diagnose, treat, measure, and move on. Long COVID doesn't work like that, as we have seen today in this wonderful, informative presentation. Kids are often moving along a continuum with fluctuating symptoms, relapses, and complex patterns that a short clinic visit cannot usually capture. Too often, decisions are based on brief snapshots, while families live the full picture, the routines, the post-exertional crashes, the symptoms that change over time, over age. And so care cannot stop at one appointment or a family physician's door. Canadian children living with long COVID continue to be invisible in charts, in schools, and in data. And so the hope is that the Children's Long COVID Network is going to work to change that. We're building a continuum view of pediatric long COVID so kids are not reduced to a single moment in clinic across all conversations at a national level. We're elevating parent and guardian observations as longitudinal evidence because families see patterns that sometimes clinicians cannot capture in one visit. We're pushing biomedical research and treatment agenda because we know, as we heard today, that it's a biological illness and it's not just a waited out situation. And finally, we're keeping the conversation active across systems nationally by connecting families, clinicians, and researchers. And our hope is that we will turn the lived experience into action. So in the honor of Pediatric Long COVID Awareness Week, I want to invite you to join our private Children's Long COVID Network Facebook community. If you're a parent, a clinician, or researcher, and we would like to engage with you. If your child is living with long COVID or post-COVID symptoms, you are welcome here. So I will share with you the, I think I just have to go back and just share the slide. So this is whoever is interested, whether you are a clinician, parent, or youth living with long COVID, please use the QR code to come and join the Facebook community, and that's where we have started. Thank you.
Thank you so much, Andini, for all your important work and advocacy for children and parents of children living with long COVID in Canada. Pediatric long COVID is not a rare disease and can have lifelong impacts on growth and development in children. Unfortunately, as cases of COVID infection and reinfection occur, the numbers of children with long COVID will continue to increase. Globally, governments need to acknowledge the prevalence and severity of long COVID in children and increase funding for resources to help children with long COVID now, as well as research into future treatments. Thanks so much again, Dr. Gross and Dr. Yonts, for giving such a wonderful, comprehensive webinar on long COVID in children. I learned so much from this webinar, and I'm sure so will our viewers. And thanks so much for our viewers for watching.